brief overview of ketamine. Really just wanted to go over the sort of the basics of it, because I know we get a lot of questions on it, and a lot of our patients in the operating room, because of this new push for opioid sparing multimodal anesthesia and analgesia, have been getting ketamine, and we've been using it more frequently over the last 4 or 5 years. So a lot of the questions come up is like, hey, what do I need to look out for when a patient's received ketamine? You know, and that's of concern when the patient comes out post anesthesia and they've had, you know, everyone's kind of familiar with opioids. You know, anybody, in your PACU training, you get a lot of training with opioids, but maybe not a ton with other analgesics such as ketamine. So, next slide. So just a brief introduction. Ketamine was sort of discovered and synthesized in 1956 and approved for use in the US in 1970. Initially it was used in veterinary medicine on dogs and horses to sedate them for various medical procedures. It really sort of came to the forefront as far as medical use in humans during the Vietnam War, where it was used as surgical anesthetic and analgesic for injured veterans. Recreational use sort of increased during that time, so because of its hallucinogenic and dissociative effects. And what do I mean by hallucinogenic and dissociative? Dissociative, sort of, the best way to sort of explain it from a practical standpoint is when you see a patient who's received ketamine, they often sort of have that spacey look. They're kind of looking up, they're sort of dissociated, they're not really aware of what's going on. That's sort of the best way to describe it in sort of like a clinical, practical terms. Hallucinogenic effects, you know, in the doses that we use them for analgesia, they don't necessarily, we don't normally see that. You'd have to use these really high doses of ketamine. So usually, in the operating room, when we're dosing ketamine, we dose it about 10 milligrams at a time, between 30 and 50 milligrams total, which is actually a relatively small dose, but 30 milligrams is sort of the dose that's been shown to provide analgesic effects without having the prominence of all those side effects. So when you see doses of like 100 milligrams, 150 milligrams, that's when you start to see all this stuff. But we very seldom use ketamine in those doses, at least here. Next slide. So some of the properties, it's an NMDA receptor antagonist. We use it for analgesia, sedation, and amnesia. So analgesia, that means pain control, right? So we sort of already touched on the multimodal approach, narcotic sparing, and I'll sort of go into why it's different than opioids in a couple more slides. Sedation, same thing. Now, sedation, something that we don't normally see in the PACU, but we have done on occasion in AOD. Sometimes we get a patient who's agitated, who's developmentally delayed, but is an adult patient, and it's not safe to do a mask induction in the operating room. And some on rare occasions, we'll actually use ketamine to sedate the patient so that we can place an IV. And I'll sort of talk about the routes here in just a second of how we do that. You know, the onset of action, if you use it IV, a few seconds, IM, 1 to 5 minutes, and the duration of it's a couple of hours. Obviously, the bigger the dose, the longer you're going to kind of see, but 2 hours is usually the time frame, the duration of the drug. Now, when I talked about sedation, using ketamine for sedation, yes, you can use it through the IV, but to achieve like the sedation that you want, you'd have to use it in relatively high doses, which we have done on occasion. However, with the IM, we will dose it anywhere from 2 to 4 milligrams per kilo, and then use it IM, and we can actually see the effects in about a minute. and the patient will get that dissociative sort of effect, and they'll let you actually start the IV. Although the biggest challenge with those patients is getting close enough to them in order to administer IM. I've done that probably in the last 5 years that I've been here, maybe like once or twice. Next slide. So that's just the chemical structure of ketamine, just there for y'all's interest. Next slide. So the clinical uses, anesthesia. So induction agents, y'all know about propofol, etomidate. Ketamine can actually be used as an induction agent. In setting here, we don't do a lot of trauma, and we don't do a ton of like hemodynamically unstable patients, at least to start with, unless they're coming from the ICU or something. So we generally don't use ketamine as an induction agent, but the reason why it does have some use is because of its hemodynamic profile. It does not drop blood pressure or heart rate. So it preserves that hemodynamic status. So if you have an unstable patient who's hypotensive, ketamine can be used as an induction agent to preserve their hemodynamic stability. As far as analgesia, that's kind of what we care about in the PACU setting. Acute pain. So of course we use it in lower doses than we do when we're inducing anesthesia, and it's best used in opioid tolerant patients where opioids are contraindicated. So of course, when you have a patient who is resistant to opioids, who's been on chronic opioids, we're starting to look for other analgesics that have a different mechanism of action that bind to different receptors. So of course we're using NSAIDs and we're using other anti-inflammatories. This is where ketamine comes into play. It's an NMDA antagonist, so it acts on a different receptor and provides extra analgesia for those opioid tolerant patients. Also, as I touched on before, all of our service lines, neurosurgery, urology, gyne, we're really trying to spare as much opioid, at least the long-acting stuff, as much as we possibly can, because more and more those patients are being sent home the same day. So we don't want them overly sedated, and we want them to be able to we want their pain to be controlled, but not be overly sedated. So ketamine provides that level of analgesic, has a relatively short half-life, and we're able to spare that opioid and all the side effects from it by supplementing with ketamine. Now, ketamine's not going to be the be-all, end-all. In other words, you can't just go, okay, I gave the patient 50 of ketamine, we're good. It's more of an adjunct. So you have to give the anti-inflammatories, you have to use the local, you have to do all of the other things that we have been doing, and then ketamine sort of has a role there, but it's not a standalone type of analgesic. As far as chronic pain, that's kind of beyond the scope of this talk, but you guys have probably been seeing a lot of press about ketamine clinics and use in chronic pain and depression and things like that. So there is a role for ketamine, and I'm doing a talk later this month that will sort of go into that in a little bit more detail. Next slide. So the pros. Why do we like ketamine? Because unlike opioids, it does not depress the respiratory drive. So we give ketamine, they don't start breathing slower. So we do like that. And I touched on the favorable hemodynamic profile. It actually raises blood pressure and can raise heart rate. And the other thing we like about it is that it protects the airway reflexes. So in other words, the patient will still have a gag, they'll still be able to protect their airway, and so less of an aspiration risk when the patient is sedated with ketamine. Alternative analgesic to opioids, we sort of talked about that. And the other thing that we like about it is that it provides bronchodilation. So asthmatic patient kind of has somewhat of a benefit, has a more favorable profile when you're dealing with those asthmatic patients. Next slide. What are the problems with ketamine? Of course, any drug that you use, nothing's perfect. They all have side effects. The main thing with ketamine is the hallucinogenic effects. Give it in high enough doses, Patients complain of nightmares, hallucinations. They don't, they see things, and it's actually it actually being quite off-putting for the patient, because they will remember when they were on ketamine and they were like seeing things. So nightmares and dysphoria, and if somebody has underlying psychiatric issues, it may not be the best drug to use. Tonic-clonic movements, sometimes it'll look like they're seizing. Not in the doses that we give here, but the higher the doses, the more likely you are to see this. So 30 to 50 milligrams, unlikely. You get to 100 milligrams, 200 milligrams in a short period of time, you may start to see that. Nausea and vomiting, it's one of the side effects there. Raised blood pressure and heart rate. So if the patient at baseline has high blood pressure, high heart rate, you give a high enough dose of ketamine, it'll exacerbate that problem. Increased oral secretion. So anytime I give ketamine, when I talk about giving it IM, I actually give it with Robenol, because the patient will start to have those secretions, which is sort of counterproductive to what we're trying to achieve. So next slide.
Yep. There we go.
That it?
And that must be it.
There's one more. So yeah, so that's basically it. There's nothing, you know, there's a few studies out there about the use of ketamine in the operating room. One of the ones that stands out is this meta-analysis that they did for spine surgery, looking at opioid consumption 4, 8, 12, and 24 hours after the procedure, and the morphine equivalents were significantly decreased in all of those. So using ketamine for spine surgery specifically has been very well described, and we pretty much do it for all major spine now because of the ability to spare opioids. So a lot of different clinical uses. For what you all look for in here, the dose is usually between 30 to 50 milligrams. And what we're really trying to do is reduce the level of narcotics that y'all are having to supplement with and that we're supplementing with in the operating room. But we're not using ketamine by itself. We're using it with magnesium, anti-inflammatories, and local anesthesia.